Imagine having an enlarged prostate that interrupts your sleep, your comfort, and even your confidence, and being told surgery is your only option. But what if there were a minimally invasive treatment that restores quality of life without the downtime? Welcome to the Dr. Geo Prostate Podcast, where we bridge natural and medical science with real-world solutions for men's health. Today, I sit down with Dr. Robert Caruso, a board-certified urologist and surgeon based in Bloomfield, New Jersey, affiliated with Clare Mass Medical Center and Newark Beth Israel Medical Center, with over 25 years of experience. Trained at NYU with a fellowship in robotic and laparoscopic urologic surgery, he's published extensively on prostate cancer, minimally invasive techniques, and laser surgery. His expertise spans prostate, bladder, and kidney conditions, as well as potency restoration and neurostimulation. He's also the co-founder of MedPro Wellness and has volunteered worldwide providing surgical care. In this episode, Dr. Caruso breaks down the latest advancements in treating BPH using vapor technology, a promising, less invasive option for men seeking real relief. Let's get into it.
Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Geo Prostate Podcast. I'm your host, Dr. Geo. Looking a little different today. Where is his orange tie and vest? I know that's what you're asking if you're watching. I know some of you are listening on the podcast platform. It's hot. It's really hot in New York, guys. Really hot. And today was not one of those days to wear a tie and a vest. So you're going to have to deal with it today. As you know from the intro, it is my pleasure to introduce to you Dr. Robert, we call him Rob Caruso. Rob, thank you so much for your time this late day. You have 3 young kids and you made it happen. I cannot tell you how happy I am and privileged to have you on the podcast.
Dr. Geo, it's a pleasure to be here. Thank you, buddy. Yeah, I've told you before, we have this affinity for each other. I always appreciate your take on things and always appreciate seeing you and catching up. And I learned something from you every time.
We saw each other at the NYU conference this weekend and our last weekend. I said, well, hey, can you be on the podcast? I'm always hesitant when I know people are busy and I know when they have kids. I'm like, I'm super understanding. I have 3 of my own. And you right away said, yes, I'm telling you, I'm super stoked about this conversation. I think I'm going to learn more about you than I have just because we known each other for probably over 10 years, but we haven't spoken at length. So here's the opportunity for that. You did your residency at NYU before I came to NYU. So as you know, in one of our offices, we have all the photos of the graduation dinner of everyone going back when Herb Lepore first started till more recent. And I'm in that room often because that's our meeting room. And I look at that photo of yours in your class. I'm like, how does Rob is the only one that looks exactly the same? Just maybe 1 or 2 more gray hairs, but not many. Just more so than anybody else that I see. Looks lean, looks good. What's up with that, man? What is the Dr. Caruso longevity program like?
Well, for one, I could say NYU was a very fertile program. We had a lot of residents that had a lot of kids, many with 3, 4 kids.
That's right.
So there's something about being in the city and being there that might have contributed. But for me, it goes back to my parents growing up in Italy and bringing their blue zone diet from southern Italy to New Jersey. And, they had a large kind of plot of land on the side of the house that a friend of mine called their illegal garden because they extended it into the woods next to, our house. But
so that was where you grew the basil for the fresh tomato and fresh tomato mozzarella and basil.
Yeah, eggplant, zucchini, peppers, you name it, a lot of spinach and broccoli rabe. So string beans, they worked for their food, my parents, and put it on the table and made it taste delicious. So grew up with that blessing, and I grew to be 6'5" from, I guess, my parents' cooking and their work. And I'm the youngest of seven.
Wow.
So it was something that my parents. My mom is 98 currently. My dad recently passed, but he was
Sorry to
almost
hear.
98,
Wow.
before he passed.
Wow.
So yeah, kind of brought that, even though the lifestyle here in America is a little more sedentary, they still got to work for their food. And that's been a model for me, and something that I try to share with patients as well in terms
Well,
of
God bless your mom at
anything. Yeah.
98. Hopefully she's in decent health at that very tender age.
Yeah.
Growing your own food. Look, what's the perfect diet? I've done many podcasts on that, and it's actually more complicated than what it really is. But getting your food that's closest to where you live is the best diet. So if
Mhm.
you give me an apple that you grew in your backyard, that's way healthier without having to be organic than the organic apple that came from New Zealand,
Yeah,
right?
absolutely. Hmm.
It's nutrient dense. The apple that
Hmm.
comes from far away oftentimes loses all its nutrients. So organic doesn't mean much in that scenario.
Yeah,
So
they're
I'm
picked before they're ripe, which is a big factor,
right.
and that you lose a lot of taste in that scenario versus letting it ripen on the vine. And then,
Either you grow your own if you have the luxury of having land to do that, or a farmer's market. That's the way to
mhm.
go. You go to the
Yeah,
farmer's market, and they exist in most places. Even you have to
yeah.
travel a little bit.
By the way, there's a funny story recently of my mom who fought off a bear at 97 years old that came in the backyard because she's the old Italian woman, protective of her garden and her vegetables. And there's a fig tree
Oh
and
my.
peach trees nearby. So she basically had to send the bear a message and threw some plates at it. And then went out when it didn't leave the backyard. She went around the side of the house, turned on the garden hose, and started spraying this bear. And the bear
Oh,
moseyed on off, never to return again.
oh
So
my goodness
she
gracious.
won. She protected her garden.
Tough
Yeah.
lady.
Yeah.
Tough lady.
I mean, getting between Italian women and her vegetables,
Don't mess
or
with that.
fruits.
Or I would wonder, getting between Italian women and her vegetables and or her kids, which one should
Yeah.
be careful. I don't know. She may choose the vegetables before her
Right.
kids, right?
Right.
Hey, Rob. So we began having little discussions, right? For me, you are a great urologist from NYU. You did your residency there. So then you did your fellowship in Texas. I'm like, you're a urologist. But little by little, I learned by speaking with you, man, this guy's holistic. Like he's holistic. And you were deeply interested in the work that I was doing. Certainly when I first arrived at NYU over 10 years ago, now 16 years ago. And you were deeply interested in that conversation. Where does that come from? And what do you do with it now?
Yeah. I think in part from that upbringing and having the vegetables and appreciating that. The other part is visiting my parents' hometown frequently when I was growing up. I mean, go back there for some summers. My parents had a place in their hometown. We had kind of that blue zone lifestyle there. We had a lot of relatives that we got to see and got to know that were from there. We got to eat figs right off the tree, and they were the best figs you could ever taste. And so just the variety of food, the quality of the food, the quality of even the drinks that we had, the bergamot and things like that. It became a passion. It was a passion of my parents, became a passion for me. And then after residency, when I went out to San Antonio for the fellowship, there was a cardiac surgeon named Charles Christian, and he retired from doing cardiac surgery, and he opened up his own wellness center.
Mm.
And he would take people through a super slow workout. So, 20-minute workout, 10 seconds on the positive, 10 seconds on the negative, using resistance exercises, taken through like Barry Sears, type of program on supplements and omega-3s. And
Right.
he saw I had a little bit of sebderm nose or cheek, which I'm prone to. And he looked at it and said, looks like you could use a little omega-3 to help with that inflammatory state. I realized at that point I have this little thermostat on my body of inflammatory state. And we probably all have it to some degree, whether it's arthritis, a certain joint or a knee that hurts from time to time, depending on your diet or if you're not getting enough sleep, if you're stressed.
Yep.
So it gave me a little bit of a window into, again, a cardiac surgeon who is in a legitimate medical practice now in his retirement, it's time to do something that he believed in, back to the basics, like that blue zone idea of the shepherds working and building a fence, using your muscles. So eating well, your nutrition, and using your muscles to do work in some way, shape, or form. That became a foundation for me, and I brought that with me in my practice in urology as well.
Wow.
Throughout.
Just today, it's hot by us in the Northeast, but I posted on Instagram a photo of just taking a little bit of sun, right? A little bit. So being active outside, taking a little bit of sun. I know everybody has concerns and fears about cancer, skin cancer. The truth is that 10 minutes, a little sun, it does so much with regards to circadian rhythm beyond vitamin D production, that's part of what it does. So just natural things, nature, right? Going back to basics. As Dr. Charles Christian, you said his name is?
Yeah.
Going back to that's the core of naturopathic medicine. It does tickle me a little bit to see research on things that I learned 28 years ago in naturopathic medical school, which was like hydrotherapy. Well, what are they studying now? Cold plunges.
Yeah.
What?
Yeah.
What?
Yeah.
Fasting. Well, how much research is there on fasting now?
Right.
Exercise and movement. Thousands of papers, maybe. Sun therapy and so forth. All to going back to basics. And it's so hilarious to see. I think that's why things like naturopathic medicine and functional medicine have taken off so much at this point. So in your practice, let's talk BPH, because it's an issue that affects most men as they get older. So that's benign prostatic hyperplasia, which, my friend Bilal Shanktai, when he was on the podcast once, now he's at Northwell.
I just saw him last night.
You saw Bilal where?
Yeah. He gave a little talk on iTind, which is one of the things we talked about.
I need to get him on because I don't know anything about iTind. Actually, the only approach that I know nothing about. So if you do it at all, you can talk about it.
Yeah.
So Bilal, I had him on. I said, Bilal, is it me, or I see patients come in and they have urinary problems, and then they get prescribed prostate supplements, prostate medications, whether it's 5-alpha reductase inhibitors, your Avodarts, or finasteride, or they get prescribed alpha blockers. And there are times I'm like, I just don't think it's a prostate problem, right? I don't think they have any obstruction of the urinary pathway. And he says, well, of course, Geo, you blame the organ you have, right?
Yeah, true.
So BP is tricky. I've seen in our office prostates that are like 400 grams. So for the audience, that's a big prostate. That's like an orange.
Yeah, 10 times the size of
10
times
the
large
size, right, of normal. No urinary symptoms. Yeah, IPSS below 7. Nothing. I've seen small prostates, 40 grams for a 60-year-old guy, which is small. A lot of urinary symptoms. I'm like, there's something. I'm scratching my head. Something. So for years, I've been looking at this. So it's not just BPH. You want to treat urinary symptoms in men. That's what we're trying to do.
Right.
And sometimes it is the prostate. I had a man yesterday who's on retention. He has a catheter in, and he's going to need a medical treatment for acute care. There's no natural treatment once you get to that point, just for the audience, that I said, look, and then when they do a medical treatment that we're going to talk about, I would have done this years ago. I can't believe this is great. I feel great. I'm urinating like a 20-year-old. The point is, not all BPH and large prostates cause urinary symptoms. I'm curious to know, what is your particular approach when somebody comes in, let's say a 62-year-old man, they get up 3 times a night and they go in the morning pretty frequently, every hour or two, to the bathroom?
Yeah, I start with that holistic approach. I'm open to hearing about them and what their habits are and what they're bothered by. I'll start by asking what they drink. What's their day look like? Do they drink coffee? Are they drinking soda, juice, tea? So those are the kind of things I'm interested in knowing. How much water are they drinking? And oftentimes they don't know. So I'll ask them to try to keep tabs on that. But at least I'll get some gist of how much they're drinking to see if it's a habit of either drinking too much caffeine or drinking too much soda, juice, etc. I'll also ask about any pain, whether it's lower abdominal pain, perineal pain, lower back pain, that could relate to prostatitis, or even musculoskeletal type back pain. And herniated discs, musculoskeletal type pain can contribute to urinary frequency urgency. There's what we call an upper motor neuron phenomenon, where basically if the neurons from the spinal cord are affected, it can cause the lower neurons or the bladder itself to just contract more frequently. So they could have frequency up to every 20, 30 minutes if they have any kind of neurologic condition, but the most common one is herniated disc, low back pain. I'll ask about the sugar. Basically, if we have a lot of patients who are overweight, have diabetes, so we'll check the urine and make sure there's not sugar showing up in the urine because that can contribute as well. And history, if they have a history of smoking and they have some irritative voiding symptoms, blood in the urine.
How long is that conversation? My concern is, obviously, this is what I do for a living, and conversation can be long. I don't think you guys have the luxury of time to go through all these behavioral changes. That's one of the challenges. A lot of patients say, look, he's not even asking me about my lifestyle. It's like, well, that's not what they're trained for. And even if they're interested, they don't have time for that. So how long does that conversation last for you with patients?
It doesn't have to be very long, and oftentimes it's not. Of course, sometimes you have a patient who wants to tell you all these side stories too, and I try to bring them back to, the relevant things, but sometimes just to listen to all the side stories, and then you get a nugget of something that helps you understand better as well.
For the people listening, for the audience, you got to be respectful of your physician's time and stay on. And look, I love stories. My patients always say, thank God you're not a surgeon. You spent 2 hours talking to me before rolling me into the procedure room before doing the surgery. But even for everyone, every physician, there's only so much time. So stay on task exactly as it relates to your symptoms that you're experiencing. It just makes life easier for everyone. They can better help you. I think that's an important message.
Yeah, but most of the time I can get through that whole questionnaire in just a few minutes because it is very relevant. Again, if I hear that somebody does have chronic back pain, it'll take me less than 30 seconds to tell them about good erect posture, recommend a lumbar support when you're sitting, a good firm mattress. And one of the most important things that I recommend is good muscle tone, core strength, work on muscle tone, because you can then brace the spine. That results in less daily compression of the spine, less irritation of the nerves. And the end result can be less frequency, less urgency along with that as well. I've had these conversations thousands of times, so I can boil the recommendations down in a few minutes. If a patient has neck pain, I'll talk about a cervical neck pillow for them and not sleeping with two pillows propping up their neck. I'll address those kind of things because ultimately, even that cervical neck pain can affect the bladder, irritation of the nerve roots that are on their way to the bladder from the brainstem. Yeah,
that's beautiful.
And then addressing constipation, making sure they're eating a high fiber diet. And I talk to them about soluble and insoluble fiber, getting the mix of both.
The bowel-bladder connection.
Exactly, yeah. And there can be direct connection with pressure against the rectum that's full against the bladder, or even a neurologic connection between the two. Herniated disc can affect the rectum and the bowel via similar nerve paths. A lot of that is connected, and I think that's part of the whole patient approach is getting that intake right. And I think another important factor is how many times they get up at night. And if a patient tells me that they're getting up at night more than 2-3 times, and their bother is more at night than during the day, if they say they can go a few hours between urination during the day, the stream is decent strength, but they're mainly bothered by that nighttime problem of getting up, and it seems to be a lot of urine, then I go through a questionnaire about sleep apnea with them. I'll ask them, do you feel tired during the day? Do you ever wake up with headaches in the morning? Do you have high blood pressure? And I usually know from their history too, if they do, which is another factor. They have memory recall issues.
How many urologists you think? I think having conversations with many, many urologists, I think they know the association between sleep apnea and nocturia, which is getting up at night to urinate. And I think there's an abundance of studies to support that. I don't see many urologists actually having that conversation, and certainly referring to a sleep medicine expert. Do you see, is it the opposite? I think you're the first that I've ever heard that does that actually.
Yeah, it comes from a personal story for me. There's a background of interest in wellness, and we can get into this later, but a side business that I got into a few years after residency was founding or co-founding a wellness company with 3 other guys, and we worked on getting health coaches to provide nutrition and movement counseling for patients. So that was a passion to try to bring it into the office. This was part of, I think, my interest from the beginning, but also I think as urologists, we're on the front lines of this problem because getting up at night or producing a lot of urine at night, patients come to us with that complaint. And it's not always a prostate problem, but it's a urinary problem. So I think as urologists, we could do better. And I think for the most part, if every urologist saw what I saw or knew what I knew from a personal experience going through this with my mom, I'm sure they would do the same. But to give you the background of what happened with her, and she was probably in her 80s when she first developed paroxysmal atrial fibrillation. So she went to the hospital for that, got an evaluation, had a cardiac cath. Her vessels were widely
Explain to the
patent.
audience in layman terms what she was experiencing and what that really is.
So yeah, paroxysmal AFib is basically an irregular heart rhythm that happens in bursts. Heart rate could be regular for a while, and then all of a sudden it goes into this irregular rhythm.
Mm-hmm.
And it sometimes can be very fast. The rhythm can sometimes get up to 130s, 140s and make people feel lightheaded, dizzy. Their blood pressure can drop from the heart rate being so fast. So that's essentially what happened to her. She felt lightheaded, dizzy, the blood pressure would drop. And it started a pattern that I tend to see is that would happen at night, like 4 a.m, she'd get one of these episodes. So after the cardiac cath showed the heart vessels were fine, but it did show her heart was somewhat enlarged. And after that, noticing that some of the episodes from there on happened around 4 a.m, I asked her cardiologist, what do you think about getting her a sleep study? It could be sleep apnea that's triggering these. So he agreed. We got her the sleep study, and she had mild to moderate, maybe, sleep apnea. It wasn't that stark, but it was there, the sleep apnea. So, we talked to her about some treatments, and she tried a mouthpiece. It didn't really make much difference. It was uncomfortable. She wouldn't keep it in, but she refused the CPAP, as many people do initially when they get the diagnosis. She declined to use that. And then fast forward a few years, 2-3 years, the paroxysmal AFib became more frequent to almost permanent AFib. But also she started developing lower extremity swelling. And she would sometimes go to her cardiologist and he would do IV infusions of Lasix in the hospital, just outpatient infusion.
Diuretic.
And she was on diuretic. Yeah. And she was on a high dose diuretic taken orally every day as well. Would have to pee a lot then during the day and at night. But also I knew that she was getting up a few times a night before that. A few years later, she got another echocardiogram, and now at that point, her right heart was starting to dilate. So the right heart dilation is what also contributed to the lower extremity swelling. So I kind of worked out the physiology even in my mind. I know that the pulmonary arteries, when there's low oxygen tension in the lungs, they're going to constrict because their job is to try to shunt blood wherever there is good oxygen flow. Right. When the whole lung doesn't have good oxygen and they all constrict, it's putting more strain on the heart. Yeah. And it's that strain on the right heart that is causing it to dilate and causing those valves to dilate. I mean, this is similar to hydronephrosis, what we deal with.
That's a protective mechanism for the body so that you don't die, actually. The heart is working even harder to get that blood because it doesn't know why there's constriction. It just knows that it needs to work harder, particularly for the brain, to get enough blood to the brain. Yeah, it's fascinating how the body works.
Yeah, and the other interesting thing, and I think the thing even about nocturia with sleep apnea that probably many people don't understand is that when the brain is calling for more oxygen, it's sending messages to the heart, raise the blood pressure, I need more oxygen. So then blood pressure can go up very high during sleep. And it's that high blood pressure that then triggers baroreceptors in your carotid, in your atrium, to secrete atrial natriuretic peptide, brain natriuretic peptide. These are diuretics. And what they're trying to do is lower the blood pressure. So one part of your physiology is offsetting the other part of your physiology. So it all starts with not getting enough oxygen to your brain. And one thing's trying to increase the blood flow. The other one's trying to lower the blood pressure that's too high. And as a result, people are getting up to pee many times at night because you're producing that diuretic.
And stopping the production of anti-diuretic hormone, ADH, at the same time, right?
Yeah.
Anyway, we could do a whole episode on nocturia, which is fascinating, but go ahead.
Yeah. I think another part of the treatment too for many patients who have sleep apnea is Viagra or Cialis, a PDE5 inhibitor. It can help dilate the pulmonary arteries, improve the blood flow through the right heart. That helps take strain off the heart. That can help reduce swelling. When I saw that right heart dilation, I then talked to my mom's next cardiologist. Do you mind if we put her on a little low dose of Viagra? So we put her on sildenafil, 20 milligrams.
What was his reaction because he obviously he didn't know the connection. You had to explain it. And I'm sure he said he trusts you and everything, but that's actually comical.
Yeah.
Hey, mom, 80-year-old mom, you need low dose Viagra, mom.
Yeah. Well, he was very humble and kind. He said, "You're the smartest urologist I've ever talked to."
Certainly out of the box thinking.
Very brilliant guy himself, and he was open to it, and we did it, and it helped lower her use of the diuretics. She, instead of using the diuretic every day, instead of going in for IV infusions, once she started using the CPAP machine, because by then she agreed to using it, and then got on the low dose of that sildenafil nightly, her swelling went down on her legs. She would use a diuretic maybe 3 days a week, not every day. So her quality of life improved. Her gray hair started turning black again. I could swear she was
Wow.
reverse aging after this.
Was
And
that due to the Viagra? Should we all
yeah,
start?
could be.
My beard is white, man. I'm not on Viagra. Maybe.
I mean, don't get me
And I
wrong,
see you
still
have
very
dark
good.
hair, Rob, and I think you might be either my age or a little older. I think
Mhm.
I know your trick as well.
Good genes, I guess, was part of it too. I don't
So
know.
it's not the Viagra. Okay.
Uh, but it could have been the young kids we had that brought her joy too later in life.
That's right.
But there's something that turned around. But definitely, I mean, it seemed to me at that time she wouldn't have lasted a few more months with that physiology that was happening, and things turned around, and now she's stable. Using
At
CPAP every night,
98, I think you
using
said.
98, using that low dose sildenafil at night. I apply it to if I have a male patient who has BPH symptoms, and if he does have frequency as well, if he does have any hint of sleep apnea or nocturia, tadalafil for that patient once nightly may be a go-to med. That'd be a good first-line med because essentially you can treat 3 different conditions with that one medicine in that patient. You can treat ED, help improve their erections. You can treat urinary problems related to the prostate by relaxing the bladder and the prostate with the medicine. And you can dilate the pulmonary arteries and improve blood flow during sleep in men who are prone, who have sleep apnea.
If I can add to that, right? So a lot of people are listening and they come to me and I said, look, you can benefit from 5 milligrams of Tadalafil. And I say, wait a minute, I'm seeing you to give me natural things. I have to say, first of all, there are pharmaceuticals that have more side effects than benefits for sure. But there are some that are game changers. And I have to say, 5 milligrams of Tadalafil daily it works like a supplement almost, except
I was,
right? It's like a supplement based
yeah,
on how it works in your body, all the benefits you get from it. And the dosage of 5 milligrams, I've never seen a side effect from anyone taking 5 milligrams of Tadalafil a day. It is remarkable. And I'm so happy they studied it for BPH. And I think a recent study showed some cardiovascular benefits as well, like your mom
hmm
benefited from. So
yeah.
it's a remarkable approach for the audience listening and watching. Don't rule out anything. Like there's no natural person more than me ever. And so if I'm telling you, hey, this thing has legs, this thing is real, like I tell my patients all the time, I think that you want to consider it. Don't never be so close-minded about some of the pharmaceutical and medical options out there, right? Right?
Yeah.
Wouldn't you agree, Rob?
Yeah, absolutely. I'm very aggressive with that medicine too, in a sense that if a patient is on nitroglycerin, if they have a condition, I'll ask the patient, talk to the cardiologist, see if you still need that medicine. I wouldn't use it in combination. It's contraindicated to use together, but I would push the cardiologist to see if they could do something to get the patient off of nitroglycerin because there are even cardiovascular benefits in physiology to using tadalafil that I think outweigh. It's one thing if it's unstable angina, that's a different story. That's chest pain that can happen randomly, but outside of that, I see more benefits to the patient being on that class of medicine than nitroglycerin, even for the cardiac patient. And yeah, I tell patients all the time, I mean, there are studies of groups of thousands of men in 2 different groups. There is no increased risk in heart attack. If anything, it's a tiny bit lower risk of heart attack, but not statistically different between the 2 groups. But it's not an increased risk of heart attack with people on that medicine. And sometimes we see somebody with a little reflux or a headache related to it. So occasionally you do see that, and maybe 1% of the time, some muscle aches as it relates to tadalafil. But I agree with you. For the most part, I think it'll almost be looked at like a vitamin and
For
how
real.
generally safe. And like I said, for older people especially, I think there are often more than one benefit from the medicine.
Rob, let me ask you a question. When you have to move on to more aggressive guns for BPH, I'm sort of okay with the alpha blocking receptor drugs, right? So these are your tamsulosins or your silodazine,
Mhm.
Rapaflo. And why? Because actually it works. It opens up the channel and minimal side effects. Sometimes you have retrograde ejaculation. And I've spoken about that with numerous other urologists recently. And it's a good next drug that very minimal side effects. Your opinion on 5-alpha reductase inhibitors. I'll tell you mine, and hopefully I'm sure that's not going to influence yours.
Hmm.
I'm not a big fan. I'm not a big fan because I think you do need DHT. I'm not in favor of dropping DHT necessarily. That's dihydrotestosterone. I don't see great results. It does shrink the prostate 20, 30%, but we already said that shrinking the prostate or enlarged prostate is not always the issue. I don't see great urinary symptom relief from it. So more downside than benefit. What are your thoughts on that?
I used to be a speaker for dutasteride or Avodart back over 10 years ago, so that's long in the past. However, I know the medicine well. I have a comfort level with it. And I do think that, this comes back to the right patient or what are the things that are most important to the man. So if I have somebody who's 80 something years old and not concerned about their erections, not concerned about their libido, and they have a very large prostate, there is a nearly 60% reduction in urine retention on it, nearly 50 to 60% reduction in hematuria developing from the enlarged prostate.
So blood in the urine.
Yeah. So gross hematuria developing from it. So it can reduce the risk of urine retention, can shrink the prostate 15% by 6 months. 20%.
Does it relieve the symptoms? I guess that if sometimes a big is, it could be too big, right? It starts pushing up against other tissues around the pelvic area, or it can be contributory to urinary symptoms. The perfect patient. So I love this because I don't want to be closed-minded. And at the end of the day, who cares about my biases or what I'm against? At the end of the day, the patient just wants to feel better and do better.
Yeah.
So the perfect patient for either finasteride or Avodart is probably older with a alpha receptor blocker.
The performance of the alpha blocker can be overshadowed by the dutasteride or finasteride beyond a year. So for the first year, the tamsulosin, Flomax, alfuzosin, those alpha blockers will outperform the dutasteride because the 5-ARIs, the finasteride, dutasteride, take time to gradually shrink the prostate. So like I said, by 6 months, it might be 15, 20% smaller. By a year on average, 25% smaller. By 2 years, 28% smaller on average. The prostate size decreases, but then it levels off with time. And it's that gradual decrease that eventually, when it comes to symptom scores, if you consider the two, it will outperform the tamsulosin beyond a year. So long term, it does have more benefits than short term. Patients don't expect to see a difference in a few weeks or a month. Rarely, just beyond a month, people start to see improvement, but really more like the 3 to 6 months mark. They'll notice they're getting up less at night. Their urine stream is stronger with it. So I definitely see the benefits, and I wouldn't necessarily consider using it for a small prostate.
For younger guys, maybe?
Yeah, exactly. For younger guys, if they're really concerned about their erections or libido, it's the last thing I would reach for. But, sometimes I have the occasional 40, 50-year-old patient with a large prostate that's either in urine retention or very close teetering on urine retention. I think it's very appropriate if somebody's like teetering on urine retention, at least as a bridge. I might talk to them about other treatment options from there to try to get them off that medicine. It's a good start to help keep them out of the emergency room for retention. Because some of those patients, all it takes is stress, a cold medicine to constrict the prostate a little more, and then they're over the edge and in retention.
Have you dabbled in any dietary supplements for prostate health?
Of course, saw palmetto, and you have a lot of patients that are interested in it. It's often very patient driven. But a few years ago, Flomentum came out. I'm sure you've heard of that one. They had an interesting story where they actually bought some of the saw palmetto plantations, and they would let the berries ripen, and then they do a pressure oil extraction of the berry to get the more active ingredient out.
Right.
So, their story is that saw palmetto that's coming from the ripe berry is a lot different than a lot of companies that will buy the cheaper green berries and basically mince it up into a powder and sell that as saw palmetto. I think there potentially is a stark difference there. And they've studied it, and they have Uroflow data. They have symptom score, IPSS symptom score data on it that did show in their studies similar improvement to tamsulosin, but with less side effects.
Right.
So that opened me up more to saw palmetto. I had offered it in the past. Those patients who really didn't want to take a prescription medicine, I think it can reduce symptoms. And from their studies, they showed that patients who are on it for more than 3 months tended to see more benefit than shorter term than that. So, Yeah. So I think for the lower side effect profile for the younger person or somebody who's averse to being on prescription medicines or their side effects, I think the side effect profile, I think, warrants that as being within the toolbox for us as urologists too.
Maybe I'll start using more saw palmetto that I use. You'd be surprised. I don't use it enough because of those issues of quality control. I
Mm-hmm.
know about the extraction process. I had trust issues and I didn't
Mm-hmm.
have the time to dig deep because when I recommend things, I just dig
Mm-hmm.
very deep. Where is it coming from? Where is this herb coming from? And I think that as I consider myself an herbalist, I was part of the American Herbalist Guild for a while. You use herbs, you don't use single herbs in herbalism. You use multiple herbs because it's all about their synergy versus the individual botanical. That drives a
Mm-hmm.
scientist crazy because they want to know, hey, which one of these all working? They're all working this
Yeah.
together. Consider it one. So it's a different way of thinking. And I use things that reduce chronic inflammation in the area because oftentimes a lot of
Me
this
too.
is inflammatorily induced. So there's things like quercetin and
Mm-hmm.
curcumin. Boswellia, actually, I use often, and most
Mm-hmm.
people don't even know Boswellia, Indian herb used as an anti-inflammatory for joints, actually has good systemic anti-inflammatory benefits for the prostate as well,
Mm-hmm.
and so forth. I mean, I'm going to do a whole podcast on that, so everyone stay tuned for that on supplements for BPH and the approach. And I'm definitely going to look up Flomentum, and even if I don't yet prescribe it, I'll talk about it based on the research that I look at. All right. So person needs a medical treatment. My goodness, are there a bunch of medical treatments out there today?
Mm-hmm.
It used to be back in the day, just do a TURP, it worked well. And now there's a buffet of medical treatments for BPH. When when industry comes to you and say, Dr. Caruso, you got to try X. You got to try Rezūm or whatever, and you already have your system in place, whatever that is, and we'll discuss that. How do you switch? Or are you just comfortable with what you do? Because,
Show me the data. And I got to first
well,
feel
no,
comfortable with the data on something.
let's be honest here, right? It's also the feasibility of doing the technique. Because, Rob, I've seen people after every BPH treatment, and I can't tell you one is better than the other. They're all good, right? Now, we can get into the nitty gritty, ejaculation, erections, incontinence.
Yeah.
We could get into, but in terms of urinary function, everybody does well with everything, right? They're all good. Green light laser, Rezūm, UroLift,
Mm-hmm.
aquablation, HoLip, and they all
Yeah.
do well. So I think it's so feasibility, your ability to do this and not have to probably go to hospitals and things like that probably plays a role. Correct me if I'm wrong and tell me what's your approach.
Yeah, so I think it's a very individualized. So it's good to have several different tools in the toolbox. And I think a lot of it depends on what's predominant in the patient's symptoms, how concerned they are about ejaculation. That's a big factor when it comes to doing procedures, because several different procedures can affect ejaculation, some to a higher degree, like doing a TURP, transurethral resection of the prostate. And what I do in my practice for some of the larger prostates, or if there's a median lobe, and it seems like this is not a good candidate for one of those in-office 5-minute procedures, then my go-to in that scenario is usually a bipolar TURP, because I can do larger prostates. I can do prostates as big as 300, 400 grams doing a bipolar TURP. It can take a while. It can take sometimes 2-3 hours if you're doing a gland that big.
What's a
But
bipolar TURP versus a TURP? Is that the same
uh,
thing?
So a regular TURP is what's called monopolar radiofrequency that it uses to heat and slice through tissue like a hot knife through butter. So the monopolar is basically the electrode is a positive and a ground on the patient's leg is a negative, or on the patient's body somewhere. So the current travels that far distance. In a bipolar TURP, there's a little loop that resects the tissue. One end is the positive of that loop and one end is the negative. So the current's traveling a lot shorter distance. It tends to coagulate blood vessels better, so there's less bleeding post-op. With that, 90% of patients can go home the same day of the procedure. They're dry enough to go home the same day. And With the monopolar TURP, because of that current flow, you need something to insulate around that electrode. So you could use water or something called glycine as an irrigant. But when you use those as an irrigant, if you open some venous channels in the prostate and water gets absorbed, they can be prone to hyponatremia, their sodium level going too low, and that can be deadly. It can be life-threatening if that happens. So with a bipolar TURP, you can use saline as the irrigant, and it's safer. Even if it gets absorbed through the veins, you're not going to see that same risk profile as you would with the monopolar TURP. So
Good.
there tends to be patients don't tend to need CBI irrigation, continuous bladder irrigation as frequently. It may be a few percent of the time, less than 10, maybe 5 to 10% that need that CBI or need to stay overnight. So most of it's an outpatient procedure. It still can take a similar amount of time as a monopolar TURP to open the prostate tissue, but the healing is quicker. For a period of time, I was doing some simple robotic prostatectomies, and it might be a little faster for a larger prostate than doing the bipolar TURP, but there's less on the back end, less on the post-op course for the patient in terms of recovery, less pain, less managing catheters. So I migrated to those larger.
Simple is less for the patient?
No, I'm saying the bipolar
The
TURP.
bipolar is less,
It
okay.
makes, so for a really large prostate, it can potentially take me a little bit longer to do it, but there's less, that's a front-loaded investment for the patient because on the back end, they're going to have less issues with recovery. And you can do a 300-gram prostate and the patient can still go home the same day and still have minimal bleeding post-op.
Are you doing simple prostatectomies anymore? Or?
No, not really. Still able to do them. And it might be that one patient where I just think based on the size and shape, this is just the better option for the
Also,
patient.
when you tell the patient simple prostatectomy, I don't think they're listening to the word simple and they're just hearing prostatectomy. Does that happen? And then you have to say, no, it's not what you think it is. It's not your whole prostate, right?
Yeah. Well, I'm always describing what I'm doing more than just using the terminology, at least trying. For the smaller prostates or for prostates where there's not a big median lobe, then that's where the office-based procedures can come into play. And years ago, we used to have a Revelix laser in our office. We had the generators. We just buy the laser fibers themselves, and we can do those laser vaporizations in the prostate. But they would sometimes, with in-office anesthesia, sometimes those procedures can take 45 minutes, an hour for larger prostates. So it was better to move those in the hospital. With the bipolar TURP technology. Those kind of migrated to doing the bipolar TURPs for those larger prostates and medium lobes. But the smaller ones, now in the office, we offer UroLift and Rezūm. And UroLift are little implants with a permanent suture and a titanium clips at each end that I describe it as like curtain holders holding up open curtains. It's basically physically opening up the prostate tissue. And that can be done in 5 minutes in the office.
Really? That quickly?
Yeah.
What's the in and out for the patient? How long does they come in and whatever? Once they laying down, and how long?
Anesthesia in office anesthesia. They give them a little propofol, an IV, so they go to sleep
local
briefly.
Anesthesia?
No, IV propofol. They can go to sleep briefly for that. We'll insert a little lidocaine lubricant, so that'll help reduce the pain even post-op. And then it's just inserting a little camera through a device that can deploy a needle through the prostate, deploys the one titanium clip outside the prostate, and then you squeeze the prostate open and deploy the second clip, which gets clamped onto that permanent suture. So it basically physically opens up that tissue area. And depending on the size and the length, it may need as few as 2 implants. Some prostates may need 4, rarely more than 5 or 6. That's more ideal for lateral lobe obstruction of the prostate. If there's a median lobe, it still can be treated, but it's a little more complicated trying to pull that into the prostate with the implant and keeping that implant out of the bladder. Yeah, I have seen 1 or 2 cases where, the implant, if it's migrated and close enough to the bladder where there's urine that's in contact with it, a little stone can form on that, and then that little clip may need to be removed. So it's not a big deal or big complication, but still something you have to manage.
What are the downsides of the UroLift? Ejaculatory? I'm sure there's no erectile issues. What's the downside?
Yeah, so in their reports, it's less than 1% of anejaculation or lack of ejaculation. So essentially, for the younger patient or someone where semen coming out is still an important quality, then and they want to get off medicines, or they're having side effects on medicines, or the medicines are too expensive. There are a few different reasons, but Yeah, I find more younger patients would rather not be on medicines for the rest of their life, and something like this is very appealing. Whereas an older patient, it's not a problem to take medicines for a few more years of their life, Um, and I think that overall, 2/3 of men won't necessarily need a catheter afterwards either, which can be appealing for a
Really? They
lot.
leave
Yeah.
without a catheter.
If they have trouble urinating after they wake up from anesthesia, we may put the catheter in, and maybe a third of men. The swelling related to the procedure may contribute to the need for a catheter. It's generally very well tolerated for that, and even Rezūm. There can be some pelvic discomfort. It's usually mild. Tylenol can help treat it, but we give them Ultraset, something a little stronger in case they need a little something more.
Do you need to retreat it within 5 years or so, or what's the length of time that it actually is working for the patient?
Yeah, so for some patients, it can last a lifetime. For others, the data shows at 5 years, the majority of patients, it'll still outperform medications at that point. So for some, everybody's growth rate is different in the prostate. For some, it could be after 5, 7 years, they need to go back on medicines. For others, it can be more than 10 years. We've been doing it for well over 10 years now, and we've had to retreat a handful, but not the majority. And it's, like I said, not too uncomfortable in the post-op. There can be sometimes urinary frequency urgency that may last longer, and gradually the overactive bladder can settle down with time once the obstruction is relieved. Yeah.
And so then Rezūm is the other one. I think my patients have some knowledge about it. We've had a few people talk about it here, but maybe you could go a little longer on that and more length and in more detail. What is it? And again, what does the process look like when patient comes in and they're doing a Rezūm?
Yeah. Actually, with Christopher Dixon, who was at NYU when I trained.
That's a long, I never met him at NYU. That was a
Yeah.
long time ago. It was before I came in.
Oh, he's a
Yeah.
great guy.
Actually, I
So
met him. I did meet him at a dinner, actually, and he was a lovely guy. Yeah, lovely guy. Yeah, Chris Dixon.
absolutely, yeah. And when I was a fourth year resident, he offered me an opportunity to go out with him to Colorado. He flew me out there, and we got to work on a pig model. And we basically used basically a new evolution of the old TUNA, transurethral needle ablation of the prostate, which was a needle that basically would use radio frequency, cook some of the prostate. And as that healing settles down, it can open the prostate. But it was limited by kind of char that would happen outside of the cook area. It would create this char that would increase resistance, and the heat wouldn't go beyond that char. Dr. Dixon's friend, Michael Hoy, developed this wet electrode, or basically using steam, infusing steam through the needle or through the electrode into tissue. And so when we went out to Colorado, we were with Michael Hoy, who developed Rezūm, and we were basically trying to create different size lesions, infusing saline for a little bit of time beforehand, before starting the RF, and seeing what kind of lesions we would create. So trying to standardize what that electrode would do, because basically when you infuse saline, it creates a virtual electrode. So the current can pass through that whole area where the saline is, instead of getting blocked by that char and having just a limited cook area. So now the tissue cook area basically can be larger. So you can treat a fairly large area by infusing saline through that needle in just 9 seconds of radio frequency going through. So each area where the steam is infused and the RF goes through, it's a 9-second treatment. So with Rezūm, that and UroLift are indicated up to about an 80-gram prostate. And there are urologists, including myself, that may go beyond that limit slightly, but not tremendously.
Not above 100 or so.
Yeah. I mean, it again, a lot depends on size and shape, and there's individual factors where sometimes you can push the limit a little bit. But for the most part, if you're doing a larger prostate, it means more sticks with the needle. And the more sticks you have, the more inflammation post-op. And more inflammation can sometimes mean needing a catheter for longer. So most men just need a catheter after the Rezūm for 2 or 3 days, and we're able to remove it. And after that, they can pee kind of like how they did before. And then by 10 days after the procedure, most men are urinating better than they did before. And then by 2 to 3 months, better still, because there's gradual healing. The prostate tends to open up more, take pressure off the urethra. So I tend to like Rezūm for patients who have a little bit of a posterior lobe as well, even if it's not growing to the bladder. If it's a big median lobe, of course, I'd rather do a bipolar TURP or something to remove that ball valve effect. But if it's not a huge median lobe, but there's some median lobe, I like the Rezūm because I can still treat that at like a 45-degree angle. You don't want to go straight down and potentially encroach upon the rectum. So at a 45-degree angle, you can treat it adequately and still result in some involution of that.
So your big three
posterior.
are bipolar, TURP, UroLift, and Rezūm?
Yeah, exactly. That's,
So
I think it covers all the bases for me
right.
and my practice, medicines, and of course, like I said, just addressing some of the other holistic things that can be contributing.
So a new thing comes in. Like, how do you make the decision not to replace something, a new thing, and replace it with maybe not use bipolar anymore and replace it with, how do you resist that temptation, or
Well,
if there's temptation at all?
yeah, I mean, iTind is a good example of that.
Yeah.
iTind, capital TIND. It's a new device that basically is a nitinol temporary stent. So it kind of expands prostate tissue. It has a spring-like action, expands the prostate tissue in essentially a triangular three areas. And that expansion can create some necrosis where it's, hitting the tissue, which eventually helps that area to open up more. And you leave this device in for about a week. A string hangs out of the urethra, which is used, that string is used with basically a long straw looking device that goes back over the string to help pull the device back in. It can compress back into that little straw to remove it for a week. So it stays in for a week. It creates
So
that
you have a
necrosis,
string
opens up the
coming out of your
prostate
penis for a week?
for a week with that procedure. Yeah.
Okay.
And it's good for tight bladder necks. The data is pretty good that it works well there. They do have over 4-year data, in some cases up to nearly 7 years of data that show that only 5 to 10% of men may go back on medications within that time frame after doing that. So because of the simplicity of that procedure, and the other thing is they have a video, it's a 2-minute video. So if you Google iTind and look at videos or just select videos, you can see this little more than 2-minute video that comes up, but it just makes it so easy for patients to understand. So I can put up that video and show them that device. And I have patients who are resistant to doing anything. And one is an older patient who's in retention that I still think for this gentleman, for the most part, who's around 90 and given his urine retention, living with a catheter and doing the catheter changes and the risk of UTIs, in my opinion, is still greater than the risk of bipolar TURP in someone like that who is medically optimized. I'd much rather get the catheter out and reduce that infection risk, the risk of it clogging and hematuria, the quality of life issues with it alone. Even if somebody has a year or two to live, I think it'd be a better year or two after opening up the prostate. Of course, when they're medically optimized and if their primary doctors will allow, that'd be my bias or my bend, is to try to get rid of that catheter whenever we can. But the iTind for a patient like that is a more attractive option because I could do that right in the office. It's a little bit more than just putting in a catheter, not much more.
Lovely.
Yeah. But then we may be able to get rid of the catheter after that 1 week of keeping that device in. So it does fill a niche, add something to the space. It is another tool in the toolbox.
So you're considering it?
Yeah, I've actually, and it doesn't take much. Every urologist has done a cystoscopy. We all know how to look in, and even this video can show you how to seat this device in place. So it's made in a way that's, if you seat it right, some of the extra, if the prostate is a little smaller, the extra stent portion can extend into the bladder, but it doesn't go beyond the sphincter. The way it's set up, it looks very straightforward. It looks easy. It's on a committee now, hopefully approved in our hospital, so we'll be offering it soon. But I've talked to patients about it already for those, like I said, select patients where it seems like the right option.
That's lovely. Rob, I'm going to let you go back to your family and I'll go back to mine. So your kids are probably sleeping at 6, 4, and 2 years old.
Yeah. By now they
And
are.
my 21, 20, and 13-year-old don't have school, so I doubt they're sleeping. They're all home from school. I will be spending some time with them as well. So, hey, man, I really appreciate you being on. I said that before. Thank you. It was way more than I anticipated. I'm so happy you came on the podcast. Final words and How can people find you?
In practice in Northern Jersey. So our main office is Bloomfield, Lyndhurst, and Ironbound in Newark. And through RWJ Barnabas Health, office number is 973-743-4450. Open to see me patients. Because we're part of Barnabas Health, they do accept a lot of different insurances. So sometimes the new patient wait time can be up to 2 months. We often, when there are cancellations, fit those patients in. We move them up
What did they
from
tell you?
their
They heard you on
2 month
the
schedule
Dr.
apart.
Geo Prostate podcast. Do they get, they get in a
Yeah,
little bit
yeah.
faster?
We'll work them in. Yeah, we'll get them put in for sure.
Can you
Anything for you, Geo.
Northern New Jersey?
Yeah.
Can you repeat the number, Rob?
Yeah, 973-743-4450.
What's the website for you guys?
EHurology.com.
EHurology.com.
Yeah. We used to be Essex Hudson Urology. Now we're a division of RWJ Barnabas Health.
Beautiful.
Yeah.
Rob, thank you so much.
Thank you, Dr. Geo. It's always great to be with you, Ben.
Thank you, brother. Hey, thank you everyone for watching this other amazing episode on prostate health, BPH. How do you treat it? What do you do? What questions to ask? What not to ask, right? Stay on the topic, right? When you go see your urologist. I trust this information was valuable to you. If you're in the area of Northern New Jersey, Dr. Rob Caruso, you got to go see him. All right. Much love to you all. Thanks again for tuning in. Don't forget, wherever you're watching, click like, subscribe. Not only helps you get the information when it's up, but it also helps the algorithm so that more people can find us. Take care, and I'll see you next time. This is Dr. Geo signing off. Talk to you soon.
Thanks for watching the Dr. Geo Prostate Podcast, where knowledge meets action for a healthier, stronger you. If you found this episode helpful, don't forget to hit like, leave us a comment, and subscribe to our channel. And if you want to take your learning even further, join our exclusive membership community at drgeo.com for access to full transcripts, curated resources, and member-only discounts. Your health journey starts with the right information, and we're here to guide you every step of the way. Until next time, stay proactive, stay strong, and live your best life.